relationship of GERD and idiopathic interstitial pneumonia just a few moments ago, and certainly these coronal reformation images can very easily show you the distribution of disease. In this particular case, a classic distribution of either UIP or NSIP, showing you that the basilar and subpleural parts of the lungs are mostly involved. They may also help to lead you towards the areas of ground glass rather than honeycombing for ideal biopsy. In terms of lung nodules, obviously you want to know whether someone has one or more nodules, particularly if you're planning something like resection of a metastatic lesion, if it's a sole metastasis, for example. And just giving you an example that, as I talked about yesterday, we do tend to miss nodules, and it surprises people because we seem to detect so many in radiology. But on this axial image, you'll probably look around and see a couple things that look like a nodule. But if we take that same data set and turn it into a maximal intensity projection, we see how many other nodules become visible. So these techniques can also help the radiologist to determine the overall number of nodules. In terms of assessing growth, keep in mind that a volume doubling results in only a 25% increase in diameter of a nodule. And that can be very difficult to determine visually for very small nodules such as this one. So what can help are volumetric techniques, and this is just an example in which the bidirectional measurements were the same for these two lesions, but in fact volumetrically there was substantial growth. So these types of things are becoming more integrated into practice. Still have some kinks to be worked out, but I think it's one of the very promising areas for early lung cancer detection. Pleural disease, certainly the axial image can show you areas of pleural thickening, as in this patient with mesothelioma, but the overall encasement and constriction of the right lung, I would argue, is better shown on the coronal image on the right. And certainly very powerful once we take the multiplanar CT data and combine it with PET imaging in this patient with mesothelioma, showing disease at the apex, a lot of pleural effusion, but also pleural disease extending all along the costophrenic sulcus, approaching the diaphragm. And then lastly, what about the chest wall? Well, multiplanar and 3D CT can be very helpful for delineating and helping to plan surgery for chest wall abnormalities, anything from thoracic outlet syndrome, chest wall neoplasms, to pectus excavatum, as shown in this sagittal reformation image on the right. Now, I mentioned earlier for superior sulcus lesions that MRI was preferable to CT. Thoracic outlet syndrome is another area where MR has a bit of an advantage over CT. But again, if you have a patient with a pacemaker or another contraindication, keep in mind we can do these patients in different positions with separate injection rates on CT. And this is a patient in neutral position, and we see the right subclavian artery here. And then with a change in posture, we see only a mild degree of narrowing in this particular person in the costoclavicular space, and again, your right subclavian artery. So this is a potential option for patients with suspected thoracic outlet syndrome who cannot undergo MR imaging. So the last thing I'll touch on are just practice options and tell you a little bit about what we do in my practice and what some things are that can be done in the near future. So there are a variety of ways to have these images presented to you as a surgeon or any other type of physician. The technologists in radiology can do a number of these things routinely on the console, and we have routinely for every chest CT, coronal and sagittal images. Just wanted to get an idea from the audience, how many of you have sagittal and coronals provided routinely for all of your cases? That's terrific, and I'd say that's at least half of the room. That's fantastic. Standalone workstations are usually necessary for doing 3D imaging, and a number of departments will have dedicated 3D imaging labs. How many of you know if your radiology department has a dedicated 3D imaging lab where they do 3D work for you? So it's still a significant, maybe 1 in every 4. One of the newer things that's happening are these thin client applications, which keep the thin section images from the CT, which are best for doing the 3D images, in a separate circuit, so to speak. and they can send those to the radiology workstations. They can also send them to thoracic surgeons, orthopedic surgeons, vascular surgeons, or others so that they can actually interact with them on their own. And then finally, a number of the PACS vendors have started integrating the ability to do multiplanar and 3D images on PACS so that if you're pulling up a case, you can start doing fly-throughs and external reconstructions without having to go to a different type of a computer. So at my department, we have a number of routine protocol type of things for aortas, for airways, where everybody gets 3D multiplanar reformations. We do routine coronal and sagittal for all cases. But then we also have MD directed. You know, if there's a tailored case, something that's very complicated, we like to specify the protocol for things like EKG gating when we get our hands on as well. So again, we have routine tech directed, and then we have MD directed data sets. And this image is just to remind me of the whole idea of global PACS. It's very important. You know, I think a lot of radiology departments are set up to serve the needs of the radiologists best. And there's really been a paradigm shift now in terms of trying to provide optimal ability for non-radiologists to review images in ways that are convenient and meaningful for them, and to interact with the data sets in ways that they can plan procedures and discuss things with their patients in an optimal environment. So again, just, you know, in my department, we have a protocol, lab and tech things, 3D workstations. We're getting involved in the thin client servers for radiologists and are working towards trying to get them out to our referring clinicians as well. So wherever you are right now, I hope that everyone will eventually reach a point where they're able to use these very freely for planning purposes, interacting with them, and also as a way of helping to communicate with your patients about their diseases and their planned surgeries. So thank you very much for your attention.